And then good morning, Professor and fellow. Today, I would like to show one EGM of a patient, 21 years old, male with chest complaints of recurrent palpitations every day and sudden onset, sudden stop with maximum durations of 10 minutes. Patient has a past medical history of cerebral palsy. TE in 2023 is normal with ejection fractions of 62%. This is his toilet ECG. Show that he is in sinus rhythm without any abnormality. We saw a toilet ECG in the 3-day ECG patch show that the patient has paroxysmal supraventricular tachycardia. QoS so a little bit wider by compared to the sinus rhythm QoS, but we cannot know any morphology of a left bundle or right bundle because there is only one lead. His chest X-ray is normal. So we start the EP study on the patients.
Go back there to your tracing. Look at this. So you have but you're saying that you have a 5-beat abnormal rhythm initiated by this S whatever you're saying wider complex. And then look at the termination. In termination, you see clear cut keyway. Nice, sharp. After that, that go the last 3 beat, last beat.
Last beat.
Very end one. No, science. Is it the P wave?
This
Is
is
it the P wave?
yeah.
So look at the P wave on the your first 5 beat. They're same? Huh? The same?
Look like not the same.
Not the same. And then also, if you look at the very first bit of normal, P wave is upright, right? Clearly.
Yes.
Then subsequently you have notched the P wave start coming. Okay. And then keep coming. Okay. And then last one has 2 together. So how do we explain this? Is this the different P wave? Or this ectopic rhythm? Or you think it has a truly normal sinus rhythm?
I think this one is ectopic rhythm.
And then if you look at that bit, you're talking that bit, very bit, as somebody said, the N. That could be a fusion bit because the QRS look different. Slightly wider.
This one?
No. That's before that one. Yeah, they just passed. Yeah, that one. That QRS.
Oh,
Is it not same? Look at the upstroke.
sorry.
Look at the upstroke of that. P upstroke. Much wider than preceding one.
Sorry.
Okay?
Yes.
So, as I said, when you look at the tracing of a beginning of a tachycardia and termination, will give you an answer. What this is the most likely. So, what do you think of that widening happening? So, somebody could argue the pre-excitation, or it is some sort of So, and then you see that complex and subsequently has another one because the following T wave has a notching on the upstroke. No. That one up there, then yes. So you see how the subtle changes can happen in EGM, so you really need to be looking at it, okay? So my mind, I think tachycardia started that slightly narrow complex and then got sustained, okay? So that keep that in mind. Okay, so looking at this tracing, what would you say? This is a long RP tachycardia, is it short RP tachycardia or intermediate RP tachycardia? How do you classify this?
I think it's a long RP.
Long RP?
Yeah.
That's what you said? Okay.
Or long RP.
Okay. So what's the definition of long RP or short RP, guys? How do you decide? Just looking at it? Do we have any definition of what is a long RP, short RP?
Long RP, it means that you mean the definitions?
Mm-hmm. In short RP. So
Long,
some people say, oh, this is a long RP, or this is a short RP. Some guys say, oh, this is an intermediate RP. Well, confusing, right? So we should have a definition. What is a long RP? What is a short RP?
it means that it's longer than half or all.
No. Short RP tachycardia, long RP tachycardia, depending on relation to the S segment. Okay? What is a typical S segment? About 120 milliseconds or less, right? When you say distinctive deformity within that range, can be short RP tachycardia. Because when tachycardia accelerates, your T wave not going to be visible. So your repolarization period can be misleading. Look at the last complex normal standard rhythm. How this patient T is short, very short. You see? So if you don't have a clear cut definition with a long short RP tachycardia, you're going to make a mistake. Okay? All right. Let's go.
I have a question. So you mean that long OP is the P appear after the as well?
P following the usually T or later after the T.
Okay.
That's the long RP, typically. Okay.
So this is our first
Okay. Now you
initial.
are going back to Cambodia, right?
Yes.
So you have a most common diagnostic available what? Chest X-ray?
Chest X-ray.
Yeah. What do you see here?
Small heart.
I'm sure you saw that tachycardia. You're already dreaming about bleeding this patient. Am I right? Isn't that what you were trying to do? You said, well, I'm going to bleed this tachycardia. Right? You're a P guy. I know how my fellows think. So then what you need to know about this X-ray before you get into the patient's heart? Well, obviously heart size is abnormal. But what is unusual about this? This patient is a relatively skinny person, right?
Yes.
And the right atrium is bulging to the right. Okay, cardiac border is more sort of a smoother left side. That means what? Right atrium may be not normal. It's maybe bigger than it should be. Okay. What did you say the patient has? Cerebral palsy. What kind of palsy he has? What type? There's several types of cerebral palsy, guys. Cerebral palsy. This is it.
I don't know.
There's many syndrome, neuromuscular disease can affect your cardiac cilia as well as the development of chest. Okay. So those patients tended to have sometimes significant chest wall deformity, which will make your procedure difficult because you're going to manipulate catheter inside the heart. And then your heart anatomy is not normal. You're going to struggle. It's not a normal patient. So when you see neuromuscular or cerebral palsy patient, you do need to examine patient chest wall very carefully. Yeah, especially if you're planning to do a procedure. So this patient has a left diaphragm is much lower than right. And then you have a pendulous heart, and then right side is shift to the heart. Okay. And then lung vasculature, relatively normal. Right. Okay.
Okay.
You can, but you need to watch those things very carefully. You don't have any other tool over there. So
Okay.
okay.
So this is our initial
Duodeca.
catheter position, duodeca in high right atrium and CS. Two quadripolar in his and OV. Initial sinus rhythm, cycle length 545, AH 95, HV 48, narrow QRS.
So patient has a baseline is a sinus tachycardia, correct? Were you giving isopropyl this?
No, we didn't get.
No thing.
Yeah.
Patient is relatively calm, lying the table. Has a sinus tachycardia rate of 110. Is that normal? 21-year-old male? Not normal, right? So that shows you that this patient overall physical condition sometimes, general weakness is possible, or the cerebral palsy patient can have other associated problems such as respiratory issue and all these issues. So these things you need to put them in your mind when you do the procedure, avoid the complications. Okay.
So we start from B passing, and we found that earlier A is in the high right atrium, 15, 16. Here.
So Artery atrium is in the lateral wall. What you saying?
There is a bypass tract in the right side.
How do you know that's a bypass? You
Um,
haven't proven to me that.
because when we do the repassing,
Mhm.
the signal go up straight to the bypass tract and
Okay.
cause the atrial activation earlier and that
Right.
side.
So you're assuming that's atrial activation, right?
Yes.
So for future your presentation, since the first bit is sinus or non-capture bit, I don't know, I think that's non-capture bit. You cut up the atrial activity there. You're tracing, I'm talking very first bit. Yeah. I can see the CS, but you don't see right atrial EGM there. Do you? You cut up. So next time, make sure you add that on. That would be much more illustrated to that's the A. I can tell that's the A or not. Okay, if you look at your first bit, look at that. I think that first bit of fusion, there's a little bit of fusion. Because your first H1516 EGM, look at the next one. Yeah, that one, 1516.
1516.
Mhm.
Yeah.
Yeah, that one initially has what? Has sparkle upright state. You see, no, just before that EGM. But yeah, that one, and you just passed. No, come back, keep coming back. That one, it is a hump upright.
Yeah.
You see that? Next one doesn't happen. And then that notching is inside whatever local D you're referring, and subsequent one is a little bit late. So that is where your B wave, A wave collide. So that is not conductor. And then next one, you have a little bit better EGM, local, you might argue local D, and then you got a whatever A. My question though, you have that broad, right after the QRS complex, whatever, the local activation, invert hump. I want you to explain that to me what that is. No, after, come back, keep coming back, right there. How do you explain that?
Mhm.
Which one is A you're talking? That's the A, or you just fragment is A? Because of that factor also exists in right EGM below. Yeah, 13, 14. So then if you consider that's a A, 13, 14 is earlier than that one. Okay? So that's one of the reason that you should be one of the local HR rhythm before your pacing. Then you can trace and you can be sure what it is. Okay? Because I have concern because that's highly fragmented signal relationship to the QRS local D is changing a little bit. But that hump rate still persists. So keep that in mind. Okay? That's good.
Okay.
Mhm.
And then this tracing,
So you induce a short rapid tachycardia, right?
yes,
Okay.
we saw that at first there is a PVC shows with the sinus rhythm with left bundle block, and then another sinus come down. But I think this sinus or maybe APC come earlier when the right bundle the right bundle is still in block, so it conduct with left with right bundle block,
Mhm.
and then another APC causing a delay in the AV node because AH here is a little bit longer
Mhm.
with a delay in the bundle brain block, so causing the tachycardia to
Mhm.
sustain.
So what you try to tell me that the since patient, the right bundle branch block, the right side is pathway DA conduction time are longer.
Yes.
That's what you're saying? Okay. Then let's go back a little bit here. You said that the first bit is the PVC, right?
Yes.
Right? RV catheter. How do you know that's RV catheter?
It's earlier than QRS.
And that's it. So how do you know it's a catheter? You could have RV PVC. But why are you saying that's an RV catheter?
The polarity reversal between 1, 2, and 3, 4.
What is the most characteristic of that? The catheter induced PVC is a PVC is straight up R wave. You see that one? Like that EGM. Yeah, this one. Straight up R wave. Unipolar will show you QS. That's why it's important to you display unipolar. So then figure out which is the artifact, which is not. So yeah, really, this is a capital PVC. However, and then what did happen? Retrogradely concealed what? Pathway? Pathway, right? That's what you're saying. But also concealed the what? Right bundle level. That's why you develop the aberrance there.
Yes.
So both way, retrograde P, ventricular activation went through the pathway direction, also the AV, anterior conducting AV number. So then subsequently PI got longer, and then you have a right bundle.
Yes.
Okay,
It's sort of a peeling back phenomenon.
peeling back phenomenon together, both sides. This is unusual pathway as well as the AV node. Unfortunately, AV node their conduction peel back was, more than pathway. That's a recover and went into the back. If their penetration was equal, they would not have backpack. Okay, this is an important concept. Okay, now you can see whether your P wave is right.
Yeah.
So where is you're saying activation pathway is located?
In 15, 16.
Why 15, 16? Why
Is-
not 13, 14?
13, 14.
Yeah, look at the first week.
It's nearly the same with 15,
No,
16.
first week. You not that one. That one, yes. The answer, right answer is what?
Mm,
Your pathway is between two,
yeah.
right?
Yes.
Polarity reversed.
Polarity
One
reverse.
is up, one is down. That means between 15, 16 and 13, 14. That's what you should say.
What about the polarity reversal between 17 and 16?
17 and 16.
Isn't it polarity reversal?
No,
In
there's a small R wave, the very first beat. 17 has R wave. That's it, that small R wave? Yeah, there is small R wave. So why are you saying that polarity reversed? Because 15, 16 doesn't just have R wave, flat. So 16, 17, you're going up, as you're going up, you got a bigger, what's the 19, 20, even bigger. That's it? Yeah, so impulse propagation. I bet your catheter is close the trabeculated crystal area, right, anterior wall. That's why you see this kind of a unusual pattern, but you're not stopping, you're not in the near. The problem of catheter placement, and especially when you're trying to do right free wall entry pathway, you want to place a catheter a little bit bigger V area. Okay, this area is pretty much atrialized part of the V, so you are not going to be able to appreciate a truly pathway activation. So if you're going to use multi-level catheter, try to localize a little more toward the tragus valve. Okay, that would be more helpful for you to manage. Okay. Okay, Chad, let's go.
And then we have a wide complex tachycardia
Good.
with
Getting
right
there.
bundle
Yeah.
brain block
Mhm.
and early and between 15, 16 and 13, 14.
So the early that notching thing that you saw, that not necessarily could be A wave, could be local just B conduction. Because your local A, when the closed one, EGM is completely different. Right? So I think it, again, try to put the catheter close to the pathway, suspect pathway area. So when you develop that, discover that, you probably adjust your duodenal catheter, so you got a beautiful trace. That's good thing. Okay. Now, the way do you think that the pathway is still 15, 16?
Yeah, still between 15, 16 and 13, 14.
Well, initial one is a V now, right? Where's the A? That's what you think A? No, B is A is behind, right? But there's a notching between two,
Yeah.
right? You see it? On the top there, that's a negative. And then 15, 16, you have a higher spike of notching, but then upright. So still 15, 16, between two. You have to map both. Your catheter moving around a little bit, but I can see it changing. That looks good. Okay.
So in the EGM, we saw that the VA is long, 140, So
The long is relatively long, right?
yes,
Mhm.
so we can explain this one because our patient has a right side bypass tract
Mhm.
and right bundle brain block. So the activation is go down through the left bundle
Mhm.
and then cross the septum
Mhm.
and then go up to the bypass tract that cause the VA longer than usual.
Yeah. Your bypass tract in the lateral wall, not there.
Oh yeah, I'm sorry.
Right? So somebody might get confused about it. So, I got a question for you. What do you think, well, how, can we tell whether this fundamental block is a proximal distal? You think you can tell us that or no? In other words, when the right bundle block happen, guys, where does it typically happen? Proximal bundle, mid bundle, distal bundle, where?
I'm not sure, but I think it is tall.
Answer is above the transseptal conduction site. In other words, left bundle activation, right bundle activates. When you have an aberrancy, what happened? You're going to retract the proximal. And then transseptal activation, retrograde conceal, that's why you develop fundamental. Okay? So left bundle activation cross the septal area, and then activate retrograde anterogradely. The retrograde is going to conceal the right bundle, become refractory. That's why functional right bundle retrograde happen. And typically will happen above the moderate band. Okay?
Okay.
So typically that's what happens. That's the most exposed, the thinnest right bundle area. That's why you bump your catheter, you develop right bundle below the his. That's the typical area. Okay. Anybody has any comment? So you make sure you fix your picture. Okay.
Okay.
You might look at the subtle pattern or something. Okay.
So this is the valid ECG showing tachycardia. We
Right.
saw that the typical right bundle brain block.
Okay.
We do some maneuver during tachycardia. We deliver PVC on his refractory, and there is an advance in the atrium.
Correct.
So AA is shorter. Confirm there is the bypass tract.
Yeah.
We do re-entrainment. We saw a progressive ventricular fusion with QRS starting
Right.
by fusion until truly passed. Confirm also the octodromic tachycardia is the mechanism of our tachycardia.
No, progressive fusion tell you what? By definition. It's showing you this is re-entered tachycardia. That's all it can tell you. If you do not have a progressive fusion, then you have to suspect it's focal tachycardia. So when you ask somebody, if it is a progressive fusion, you assuming understanding the underlying mechanism tachycardia re-entry. That's all can happen. So it's an important concept. Okay, that's how we differentiate mechanism tachycardia in the history. There's a focal, there's a re-entry, and so on, all that. Okay.
Okay. And then pole passing interval minor tachycycle length is 108. Confirm also the octodromic tachycardia. So in first summary, when we see a wide complex tachycardia with typical right bundle brain block, according to Jackman, we have 4 differential diagnoses. One is SVT with aberrancy conductions. Second is fascicular VT, either left anterior or posterior. Third, pre-excited AVRT using nodal fascicular with LBBB insertions, or a focal VT origin from LBB. The last 2 differential diagnosis is very rare because nodal fascicular normally insert to the right bundle. And we can rule out the fascicular VT in this case because H3 interval in SVT is equal to H3 interval in the sinus rhythm. So our conclusion, our patients has an octodromic re-entrained tachycardia using AV node as anterograde conductions and right superolateral accessory pathway as the retrograde conductions.
So what would be happen if you had the AVNRT with the bystander left or right lateral tablet? Would it be different?
That
So if you have a patient have adenovirus,
Yes.
tachycardia, but also has to happen to be right free wall axillary pathway, high standard. So how do we differentiate that? So you have to prove that that axillary pathway actively participate in the tachycardia, right?
Yeah.
You already done that. How?
The PVC on his.
That's right. So that is what's usually when you guys take a US EP board, every year that question comes up. Okay, you have to prove that the tachycardia mechanism is re-entry. Second, that pathway is actively responsible for the tachycardia. So those maneuvering is that's why it's so important. Okay, very good. Okay. You've done that all that. Okay, so you ablated.
Yeah, so this is our ablation catheter position before the first RA ablations. We put the large curve EPT catheter through the SL1 shift and curve to the lateral wall of the ORA to maintain the catheter stability.
Yeah.
This is showing mapping of the retrograde AP accessory pathway conduction during tachycardia because we have trouble. We cannot terminate the tachycardia. It keep continue. So we map during tachycardia. We saw that there is an accessory pathway potential, perhaps maybe that happened over the V valve.
So you have in your tracing data that that's evidence actually pathway. You have it?
Yeah, I think so.
Where it is? Go to me.
The
Not point, just looking at that is not worth it. No, you can't then do that, my friend. You have to have a tracing suggestion of that's actually pathway. And your clinical tracing needs to support it. Is it need this tracing? Is in there? I just want to hit you. Look at your arrow, sharp potential deflection, follow that, what happens? Next bit, next bit, next one, go to next bit,
next bit.
yes. Where it is? Is there a small one? And then, yes, the next bit, what happened? Next one. Disappear, almost gone. Okay, now, if you measure DA time, local time there very carefully, I bet you the last one is slightly longer than other one. Very first one is the best electrogram. First arrow you're pointing.
Yes.
And then you get a little lesser, not no ablation. Okay? Because if you look at that first complex, we got quark is the beam, broad, and then you get the sharp deflection with the low frequency noisy, and then you got A, which is inverted QS, almost QS, not quite. We wish that A to be QS. That would be a wonderful phrase, but you're almost there. So looking those changes is important. So why the QS? Why atrium should be QS? Your ablation catheter is what?
More V side.
Above the axillary pathway. Okay? In other words, is activating backward. So how do we move this catheter now? You need to go a little more ventricle. Okay?
Okay.
Because your catheter going opposite now, going to the atrium. Get A bigger. You see it?
Yeah.
So when you're mapping of pathways, you want to look at because of this A, talk about A already activated atrium, your catheter is going backward. See, it's already passed. So that means you got to move to the ventricle and this. So analyzing this EGM tell you how to move a catheter, guys. That's why I keep telling you watch EGM. The minor details are very, very important, especially right through your pathway. Otherwise, this pathway will be curved, unfortunately. Okay, so what happened?
So we burned.
You burned it? Good.
Yeah. And
The catheter
tachycardia
terminated,
was terminated within 2
and then your
seconds.
catheter was stable?
No.
It terminated?
It moved.
How, why they moved?
I think this
Because the catheter terminate, cardiac motion change, and the catheter gonna fly out of there. Okay,
Yeah.
So do you go back there? How do we prevent that in the future? That's important, right? Nothing wrong with the burning of the tachycardia. What I want you to do, measure the RD cycle lengths, okay? Tachycardia cycle lengths RD. You sync RD, systole pacing. Pace about 10, 20 milliseconds faster than RD tachycardia rate. So what happened? Your ventricular motion gonna continue paced, which is same as tachycardia. Then you start pacing gradually. Once the ventricular pacing take over, you ablate. And then you will still be able to see local VA dissociation, but cardiac motion will be the same, catheter will be stable. Got it? That's the trick. So somebody teach you, oh, don't ablate SVT. No, that's not correct. Accurate, most accurate is SVT going on, WPW, whatever, you want to ablate in tachycardia. Good, you map well, because sometimes RV pacing during the tachycardia, your VA conduction can change. Your catheter potential may not show up, may show up only during the tachycardia. Then you will burn that in tachycardia, except start the V pacing, once the pacing start, you burn. Then your catheter will not fly out of there. Okay, that's a trick. Got it? Okay, good. Okay, let's go. Then what happened? You got the right bundle still over there. Okay, keep going.
And then booster ablation, because the first one we just deliver only maybe around 10 seconds of ablations.
Okay, so you just ablate the same site.
Same site.
How do you know it's the same site?
We confirm by fluoroscopy because
Oh,
before
fluoroscopy.
ablation we self
Okay,
we
yeah, that is a problem because the fluoroscopy can be wrong for up to 10 millimeter. Okay? So keep that in mind. Your 3D mapping error range up to 4 to 5 millimeter. Real-time cardiac motion, even though cartos or whatever is at the same spot. Second reason is that the fluoroscopy even worse. No matter how good you are, you match it. Yes, you can match it, but then you may not be at the same spot as you are. So that's for the reason we have to pace ventricle.
But bypass rate is already cut. So
It doesn't matter.
how can we?
That's a problem. That's what I said. You have to pace before. Don't ablate without pacing. So you're gonna have this problem. So there's a critical early data we had, us and Sonny Jackman, everybody did this painful experience because when we did not know any of this, we ablated the tachycardia terminator, said, wow, it's good. But recurrence rate, twice more than when you have ablating in the sinus. So then we figured out how do we, mitigate this problem. So then we discussed about this in the meeting, pacing. Mel Shannon idea. Mel said, hey, guys, you guys need to pace this. He's smart guy, so he thought it was amazing. That he's the one of the kitchen. Yeah.
So I ablated twice more, weak side and A side.
But interest one? Okay.
Interest.
Okay, hopefully don't come back so quickly. Because the right free wall is very notoriously, tragus annulus catheter is very unstable compared to the left mitral annulus, because by nature of tragus annulus formation. Plus, you have to remember, tragus annulus atrial side, there's a lot more trabeculated musculature, pectineus area, and so on. Look at the anatomy compared to the left atrium. That's why your catheter stability in the right free or pathway ablation is so important. So next time, make sure you pace, overdrive, and you will be happy. Okay? All right. So your successful ablation, huh?
Yes.
Okay, good.
But after ablations,
Mm-hmm.
earlier it changed to
Okay.
the CS7A during V passing.
Right.
So we saw that earlier it
So
changed.
with ablation, your ablation is a 1-2, but located. It's in the same spot. You ablate
Yeah, we ablated.
in the most septum.
Yeah.
Okay.
So-
You said earlier, yes, definitely. But I'm concerned that the EPO ablation is in the same spot. You got a fusion there. That's my worry. Okay? Make sense to you? You shouldn't be early there. Far is right there, that noisy thing there. That is, should be later than 15, 16. Because your impulse coming to the anterior septum, turning around, comes to the lateral wall. Am I right? So you better double check this. Okay? I would be happier if that thing was moved up a little bit more.
Mhm.
Because if you look at the timing of 15, 16 and 13, 14, about the same, roughly. But that potential, small one, even earlier than that. That I'm worried.
Hopefully, I knew the rating.
Yeah, that's why I said, check it, make sure, I'm sure you'll keep it place, that's fine, but then. If you're still in the same spot, you have half a left over. 무슨 말인지 알죠? Understood? Yeah, that's important. Especially when you have such a long fragmented early noisy, that is really bothersome. Because when you ablate the tissue, they're gonna have some swelling, damage of the tissue, so conduction is gonna be delayed, very long, slow. This is one of the reason that the double potential does not mean block. Okay? Polarity have to be reversed. This is maybe, you know, tissue that has a very slow conduction somewhere. I don't know what it is. So. Okay,
And then no V8 decremental property.
Mhm. And patient did not have any slope pathway, anything like that.
There is a slow pathway.
There was a slope pathway.
Yeah, there was a slow pathway, V8 jump, and then A8 jump with single echo.
Mhm.
But after A8 jump,
Mhm. No, no.
no, yeah,
Okay.
it's slow pathway EOP.
Okay. Let me ask you this question. You right through a pathway, okay? For a 21-year-old guy, even the cerebral pulse, tachycardia rate, isn't that a little bit slower than you anticipate? SVT rate? Isn't that strange? Or not? It's normal. What do you say? Because this young man had a sinus tachycardia at the beginning, even you haven't done anything. And then, yeah, you induce SVT, tachycardia is relatively slow. And then RT intervals are really slightly longer than expected. And patient has to do everything in physiology. So you wonder whether this patient would have had slow pathway anterior conducting orthodromic ADMT. Because that possibility also exists with his evidence of tracing. When he had a PVC maybe blocked anterior inferior AD node on because they have a shorter, in longer refractory period, shorter refractory period, and then slow pathway conduction intact of next subsequent sinus, maybe conducted with a slow pathway coming down, that tachycardia will continue to persist. Sometimes those mechanisms are much more dominant because you create a more excitable gap conducting to the slow pathway, they facilitate the reentry. Make sense? So this is something that you need to think about scientifically. This is really key.
Even here, the right on the branch block,
That's right. That's another thing.
even slower.
Right, even slower. So that's what tachycardia is so slow. Very unusual, because usually neurologic patients, cerebral palsy, Duchenne, Duchenne muscular dystrophy patient, and they have a tachycardia very fast because of their respiratory distress and many other factors implying to this. And so obviously the autonomic dysfunction also. It's a rather unusual case, but this is just common. I've seen before some people feel this. So think about it, okay?
Okay,
Good.
so second catheter position at the right postural septum.
Mm-hmm.
Mapping,
Mm-hmm.
we found that there is no anterograde conductions of the pathway,
Sure.
and retrograde conduction, we found there's subtrusion between A and V.
Okay.
And then we burn at the right postural septum,
Mm-hmm.
and within 3 seconds, VA block.
Yeah.
Yeah.
Okay. So what are you saying? What do you recommend? When you ablate one pathway, patients still have a VA conduction. Should we look for second pathway? Is that a meaningful statement?
We should look for the second pathway.
Or if there's a one-to-one VA conduction, even in sinus and normal sinus rhythm, you still want to look for?
We can do a V passing as our protocol and see.
Still have a one-to-one, slightly decremental. Let's say you have left-sided pathway ablation. okay?
Yeah.
You ablated. Ablation successful. And patient still have a VA conduction. Right after ablation. What do you say? What are chances of having incomplete ablation or another pathway? Much higher.
We can
When you
check.
have a doctor without ABRT, clinically medicated, you want to see after ablation, VA dissociation. That's what you want to see. Doesn't matter right or left side pathway. When you have a VA conduction intact still, even the nodal, watch out. That pathway may be light. Very important observation. We see that consistently in many patients. Okay. Sometimes you try to be stunned. I don't know what the reason is. We have no explanation yet. People have a VA conduction, suddenly pathway comes back in 5 minutes later. So when you have a VA dissociation, much less chance to come back. So you really want us to VA dissociation.
So in such case, where do you map? Left side post rectum? Or
No, do you wait until to recover and then test again? I bet the left side of the case, mostly same pathway. Some of the fiber left. Some reason whether they do facilitate conduction, you know what that is. We have no idea. But that is a phenomenon that we watched, we comment about. We discussed many times about that with all of the ablation guys, but we have not clear idea.
but in some patients, we saw the after right post receptor bipastoral ablation recur from the left side.
Right, that's correct. But that's also, but post that's a different story. But I'm talking right free wall, left free wall. Yeah, I did a case, Ginger. 14-year kid had a pathway, so we ablated, disappeared. Completely, so, but 80 conduction normal steps. Wow, maybe young guy. So we left. And 5 minutes later, pathway came back. But just came back a little more proximal. Then came back again. We did that 5 times. Last ablation inside the CS. Then the dissociation. Never came back. So it is a very peculiar phenomenon, but I don't know if there's any publication regarding even the theory why this happens. We don't have an idea. So when you don't have a first burn, you're complete success, and you have no VA dissociation, watch out. Especially during the tachycardia burn, and then you're facing ventricle, and the tachycardia pattern changes to VA activation concentric. You're not done. The pathway is still there.
So in such kind of the complex ablation, how long do we have to wait? The
But theory,
three AP patients are waiting.
we wait 30 minutes no matter what.
30 minutes.
Yeah, at least. So you give isopropyl, test again, and then wait 30 minutes. So that's the rule. It doesn't change. 30 minutes of this possible testing. Okay. Okay. So you had a 2 pathway.
Yeah.
Mhm.
So VAD, and then 2 more booster consolidation ablations at right posterior septum. Summary number 2. So because our patient has a multiple accessory pathway,
Mhm.
right anterolateral and posterior septum. So I have a question. Is the bicomplex tachycardia can be an aberrancy or bypass track to bypass track reentry?
What do you think?
I think
Your ablation was what? Right side or left side?
first right side.
Right side.
Yeah.
Then why you should have a left bundle? Wouldn't be have a left bundle? If you have a 2 pathway conduction. Why would
Yeah.
be a right bundle?
Yeah, yeah,
Would it be opposite side?
yeah,
Right? So
right.
that theory doesn't work.
And another one,
Yeah.
our bypass track doesn't have anterograde conduction, so it cannot happen.
Maybe this since the anterior conduction of that pathway wasn't there, you only had the orthodromic ABRT. You haven't seen the pre-excited tachycardia, so that pathway maybe could be just bystander. Right? We haven't proven any data yet.
Actually, that was your homework I gave,
Yes.
right?
And I have one review at the end of the presentations about that
Okay.
also.
Let's go. Now, don't think that boost is a routine practice, okay? Please don't. You want to map much as you can, just burn 1 burn, 3 seconds block, you're done.
Actually, that was by experience. First,
Uh-huh.
my case,
Uh-huh.
after getting the faculty position, I ablate the left lateral bypass tract, a
Mhm.
single part.
Mhm.
This is just 1 second.
Okay.
So I sent patient back,
Hmm.
but the patient coming back to emergency room.
Not I got it.
Yeah,
Because did you review your lesion pattern?
I don't
Good.
remember it.
That's about. So if you done one single energy application, your pathway go within 5 seconds. And look at your energy delivery pattern impedances, they're all standard within normal parameter. Your chance of recurrence is less than 1%. That's the Sonny Jackman data. Really, really solid data. When you follow such a guideline, yeah, we haven't seen any problem. Okay, so burning unnecessarily is basically what I'm saying. You're not sure, you're sure you're gonna do boost pump, but try the best you can to avoid boost pump. That's not a standard practice. If somebody asks you on an EP board, answer is no. Okay, I can tell you that. Okay,
And then we wait and check again. After RF number 6,
mhm,
retrograde conduction found earlier at the his catheter.
mhm,
It's not in 5-6 anymore.
okay,
But in single V, there is no VA decremental conduction. So we go to the left side by transeptal puncture.
now you go back to that tracing, you're tracing over there, the before that one. Yeah, this one, what do you say?
Earlier is at his catheter.
How about next one? No, what is it between two? No, you're skipping a lot of things there, my friend. Keep going, yes, that one, what is that? That's an A or his, or what it is? Meaning if you look at even his bundle 3, 4, you have a far field of that thing. Now, go to the left, yeah, now you just pass. Read that one, yes. Not even earlier. Yeah, that's a his,
Yeah.
pocket list. I wasn't there, so I can tell you, but I'm asking a question.
I guess so.
You guess so. But if there was another bycatcher, how can his be earlier? That's how I'm gonna ask you that question. That's how I was trying to ask you. What is it we are talking here?
Is it only?
Earlier than any A there you see. Am I right? If there was another pathway, you should have conducted actually, you also not conducted that pathway. Earliest part of the A should be the target area, right? So then we are talking proximal kiss. I don't know what this is. So you need to go back and look at this straight. Okay, go ahead. So, and then what did you do? So you went to the left side.
Yeah, we burn at the left mid subtom.
Okay. What is the EGM? Let's take a look. Huh? Ovulation EGM, man.
We didn't do the bypass century ablations.
No, I'm talking before the another burn here, mid-septum. You should pace the right. You get the pathway potential something. You just burned it. What's the story here?
Probably I mapped during BPC.
Right, that's what we.
And
see that.
because of a risk of a hot
Okay,
block,
okay.
I ablated during sinus.
Size, I see.
So you missed the.
Yeah, I
BPC.
missed
Yeah,
that EGM.
It's also important, right? To validate the yield concept of posterior vascular or posterior pathway with the split fibers or whatever the reason might be. Okay. All right.
But after that, still there is no decremental.
You sure that's not a decremental? Is it not decremental? Why did you measure over there? You think that's not decremental? Chad, looking at the eyeball. Don't trust a lot of scale business. You put a wrong place. So 450, 400, 450, 260. Look at the retrograde A. Is it not a decremental? It is decremental. Okay, listen. A lot of times we measure VA conduction time, the earliest A. But also you need to look at the panoramic activation of the lateral free wall and everything else. Look at that. From steam to the whatever. You think it's still not decremental?
Mm.
In my eye, it looks like decremental. Okay? Especially his H56. First bit 450 and 260. Is that longer?
When you taught me even the damage bypass track shows a.
Yes, you can. So question is that whether it's a progressive decremental or not. Did you do S1, S2? S3?
No,
Why not?
only S1. Only S1, S2.
Okay, when you have such a doubt, or you want to exaggerate your pattern, add S3. That way you will see more evident that this is a true decremental or this pattern continue persist, right? So that's why your Bloom simulator has a 6-channel, okay? Not only 3, 2-channel. Okay. So it is important that double X. Okay, very, very important. So I would have done double X right here to prove that is. The reason I'm telling you is that this is decremental. You can look at the ablation itself. Look at the S1, S2, you know, A, let's go to A. When S2 comes in, your polarity of A reversed. Do you see it? Ablation. Yeah, reversed completely. Also, CS activation changed. Everything changed. So then you have to prove whether this is the pathway conduction, the other one's a fusion, possibility of talking, or this is just nodal path, nodal conduction. The first one would be fusion. So prove that you add S3, then you will have your answer. Okay? Yeah, so think about doing that and doing next time. Okay?
Okay. So we saw one VA jump and then EOP, early pacing. So also early at his.
So be pacing the intermittent dissociation.
Yeah, intermittent
Right.
dissociations.
And then you capture occasionally, and then even fusion bit there. So you got 2 fusion bit, progress fusion, and then capture bit. So it's different, okay?
And then
Okay.
same ISO. We start ISO 3 micro and VA decremental property. Yeah, we saw the VA decremental property after ISO.
Okay.
So we consider stop the procedure.
Okay.
And this is the ECG at discharge.
Okay. What is unusual EKG about this EKG? You said the EKG was normal. I was going to ask you that question. Patient has a relatively short, that segment? This patient. You see it? Pre-cordial, especially P1, P2. There's no really, you know, that segment distinctively visible other than pre-cordial. And then 2, 3 AVF has not. What would you say?
Early repolarization.
Early repolarization. If this is normal or this is abnormal, what it is? How many different physiologic variants we have, guys? So we call normal variant, right? It is a normal variant, assuming.
So
Well, how many different we have? J-wave syndrome is what we people call tigers all over the place these days. So how do I know this is not a J-wave syndrome?
yeah, there were too many words.
No. This is the age, 21 years old, man. So you still can, he's still young, he can have a still J-wave syndrome. And he especially has what? This EKG, hidden sinus rhythm rate relatively controlled. On the table, he had heart rate 110. So whenever he had stressed, I'm sure you did not go general anesthesia on that guy, this guy.
No,
So
I was very anxious.
that's right. So anxiety, fluctuation, heart rate variation is a young age. It's a good thing. But I'm asking, when do we say is the notching in the terminal 3 and then 2, or is a normal variant when is non-normal variant? How do we know that? That's an interesting question, right? Because otherwise you're going to make like a J-wave syndrome all over the place, right? Yes. So typically you will see people who have a J-wave syndrome in the lead 2 or 3, that segment going to be higher, a little bit higher than that. Usually we consider at least 40 minutes, 1 and then half a box above. Okay, this patient is slightly elevated, but it is not slight elevated, maybe 1 box or maybe. So there's a 4 different variants that you will see. And the variation of a J-Weaver syndrome, secondary to the hypothermia, all this, the Osborne wave, whatever people talk about. And then there's another variant that looks like a pseudobrugada, which is a D2. You have a worse T-wave abnormality than D1. That is called Adecco phenomenon. There's a variation name called Adecco. Dr. Adecco described that in 1980s. So diagnosing Brugada also need to be very careful. Okay, this patient basically just related normal, at the young age, physiologic variation. Another reason that the S segment disappear is the high rate of pump. Okay, just don't forget that, it's the important part of the EKG variation. So when you see short S segment, take a look if there's a sign of arrhythmia or high rate of pump or not. Those things could be important. In J-Weaver syndrome, you don't have that. That's another feature.
I think that artificial intelligence may differentiate.
I think so.
With recent publication
Yeah.
from Mayo Clinic
Yeah,
determined the concealed lung QT syndrome.
Right.
Q20 is normal,
but
but the AI can differentiate the
Differentiate.
genotype of lung.
because there's a lot of AI technology is much better than us, so, but you know, things come. But still, you need to learn all that. Beat the AI. You're smarter than AI, so. Okay? Any other question, guys? Okay, review.
Yes,
Oh, review, let's go, yes.
a small review. So in this study, in 1993, they show that the multiple bypass tract is around 10 to 15% in patients with WPW, and it's getting more and more with antidromic tachycardia WPW patients. And 40% of the patients that have multiple bypass tract have posteral subthalamic bypass tract, and associated with left free wall more than right free wall in this study. So also in this study, they mentioned that those 200 patients and 70 multiple bypass tract, only 1 patient saw a bundle to bundle re-entry with wide complex tachycardia. There is no electrophysiology criteria, as I know, to diagnose those type of re-entry, but we can see that in these patients, early V compared to QRS is more early in the CS distal, and early A is in the his. So probably in this case, the anterograde conduction goes through the left lateral bypass tract and retrograde through the posteral septum. Also, there is a case report by the Japanese doctor in 2021. They mentions about bidirectional AVRT using bidirectional bypass tract. In that case, they have 1 right lateral and left lateral bypass tract. So they deliver 1 extra stimulus at the atrium, and it induced a clockwise by bundle to bundle re-entry, as we can see in this EGM tracing, show that the earlier V is in the CS distal and early A is in the right lateral wall of the atrium. So the pattern goes through the activations, it goes through the left lateral and then retrograde to the right bundle, bypass tract. So they pass from the ventricle, and then it block in the right, block retrogradely in the right bypass tract, go up to the left. As we can see here, early V is in the sorry. Here early V is in the oh, I can choose.
Yeah, only in the right after the part of the peak.
Yeah,
Yes.
and then early A is in the left lateral CI distal.
There's a VA. You see, small pop is a B, sharp is a A, reverse. Okay? Hang, take a look at just before the arrow. There's a small bump. That's a B.
Yeah.
Yes, that's what you're looking. So. What you get facing the next.
So their hypothesis is that the possible reason that we can induce bundle to bundle reentry. So at least one bypass track have anterograde conductions, and the two bypass track or accessory pathway with difference is effective refractory period. One is longer and another one is shorter, right? Like in this case, right accessory pathway has a longer EOP than the left accessory pathway. Long anatomical distance between the two bypass track, at least they mentioned at least 2 to 3 centimeters away from each other. And then no VA conduction via the AV node. So those criteria can induce the bundle to bundle reentry. Thank you.
Just for the styling of. Read of 10 paper between the lines, right? That paper had a major discussion by the client. Objection about the publishing paper. May not be true because we had a national meeting 92 about that. The client didn't think that was a paper conclusion was correct. I would not read that much credit which he had this paper 93 that he showed you. Tracing quality is bad, and then your argument is not right. So, okay, don't waste the time reading.
I have a question.
Yes.
So we saw the right coastal septum second bypass track during PPC, and you mentioned because retroid kiss bundle is earlier than the local AN 1778.
Right.
It is not a bypass track remnant, but actually it
Maybe
is
the
the
diffusion.
AB
Right.
pathway. So
Right.
kiss bundle could be earlier, even the bypass track.
So postal support pathways could run through the truly mid septum. Okay. Could be right side, it could be left side, it could be cardiac vein. Okay. But these are reference to the HR agenome. We don't know where the true fiber pathway is because you're gonna have actually pathway and then you're gonna have a myocardial junction, HR myocardial junction to the pathway and then exit off, whatever. So that's why sometimes you end up with two different sites, right? So some people argument is postal support pathway perhaps it should be a blade ventricular surgery, not a vein surgery. Which then you cut one bone with them. So some centers don't do postal support pathway HR approach, they do ventricular approach. That is. However, there's a truly pathway they split even in ventricular surgery. There's a cases where ventricular surgery is not a single point, but pretty broad muscle, robust muscle. Those ones that tended to be very rough to blade. Recently, I did a case at the Kilbyoung Incheon. Hagemin Zheng had a case where a lady came to BFRS, okay, pathway, postal pathway, and she had a truly epicardial pathway in posterolateral branch to middle cardiac. You had a pathway potential all the way along. So we ablated first time more ventricularized aspect in the posterolateral cardiac vein. 5 seconds pathway went away. Interestingly, we waited 5 days. Nothing came back. She went home. Came back with another complex tachycardia condition. Not to be had a proximal fiber insertion. So we ablate that 2 weeks later. Gone. And then she calls me, she had a recurrent tachycardia about 2 months. That's a truly robust such pathway exists.
That's why we need insurance program.
Yeah. So question we have is that because the inside the cardiac vein, we do not burn all the way to the in CT scan, there was a posterolateral branch artery running right under that cardiac vein. So if you deliver lesion all the way across, how likely chance that you're going to end up occluding that artery, you're going to cause a myocardial infarction. I had a patient like that. My son is recommended that one once before, 22-year-old lady. She had never had a heart attack. So I have such a painful experience. I said, well, she does not have any more BF, so she have a regular SVT. I'd rather fail. I don't want to burn the whole thing. So there was this clinical decision-making process. But otherwise, we would burn the whole thing. So key point message that if you're messing around the postseptal area, do coronary angio. Don't do without it, please. And there is a many data supporting now that post-septal branch can be occlude 90% up to no symptom, no segment change whatsoever. There's a data beside that much already. And also moderate narrowing occur more than half the case. Okay, because it's very related to small artery, they tend to run PDA goes down, this thing goes straight across. Okay, whether you have a circumflex artery dominance or either right coronary dominance, you're gonna have that post-septal branch. So watch it do angio before you mess around that area, especially you intend to run irrigation high power. So it is very important message for you.
Is it safe after?
Yeah, so running angio, and then Sonny did 100 case of post-septal case before ablation, post-ablation angio. And he learned that a lot of asymptomatic injury of the coronary artery.
What about CTI ablation?
CT ablation, no, is further this one, so that's why. I think it is important when you go inside the CS or either from the left side or flow the coronary sinus. So those are something that we need to remember. Okay.
One more question. The concealed bypass tract, mid-septal concealed bypass tract is very difficult for us. So how do I learn new method?
Okay. Mid-septal or truly mid-septal. The concealed artery pathway is often easier to approach from the left side rather than the right. The reason is that your kiss bundle will be above your catheter, definitely, because when you come to the left side, kiss comes straight down, and then left bundle become your pathway going to be lost. Okay. On the right side, remember your area view, you're looking upward. Earlier you can look down a bit. So when you look at the area view in the right side in the ablation, you're going to be kiss bundle catheter, your ablation catheter is going to be underneath, and then you're going to transverse into the tricuspid annulus, and then you're going to look for pathway potential and look for reticular A. So basically what you see sometimes, Focal-A pathway potential during the B pacing. That's your blade. Unfortunately, you have to burn underneath the tricuspid annulus, or sometimes right at the annulus. Your lesion formation is not that great, but actually this type of pathway is very fragile pathway. You don't need much energy to deliver there. So we end up pulling back and try to blade right under the AV node and the tricuspid annulus. That's a much higher risk. You will have a junction with no matter what, but then conduction, make sure that. But so that's why we approach transaortic, go straight down, first approach back it. Then you will see during the B pacing, you're going to have the B and pathway potential. That's what you see. That's your place of blade. And
I mean, transaortic.
transaortic.
That's transeptal.
No transeptal. You can get that transeptal. That's not stable because your energy is going to point upward. You're going to go to the east bundle. You want to point down. So transaortic is better.
Or transaortic, also the straight.
Straight down, yes, to the
That's what
septum.
you use-
No, straight down. No, because you're gonna be below the east bundle. You have a non-coronary cuspid, right coronary cuspid, his bundle right there, right? So you have some room there, right there. You're going to say his bundle below that, not above.
And in area view, compare the right side, his one
Right.
right, that hand location.
You get a lower, very lower, yes, because you look up. Yeah.
You need to have a problem. That's very good.
Yeah, we map target left first. Only fail when we can find the pathway potential and they come to the right. Because this type of problem is that the patient very widely, a septal thickness from the posterior to the anterior, you're gonna get like a pyramid, right? This degree of pain information changes quite a bit patient to patient. When patient is overweight in the lying down part, it's gonna be pretty thick. When the pendulous heart is gonna be thinner. So chest X-ray sometimes can tell you, this patient gonna be maybe gonna be okay. This may have trouble. Okay, so and curiously, whether if you cannulate the septal vein, what we are doing now, all the way down, can be helpful. Although not somebody speculated many years ago, but we never able to do that because they stopped making cardiac capital. Make sense? Septal vein from all the way down. So you can cannulate that, you can record a pathway potential, you can target them off the second, you know exactly what it is. So it's not easy to test that concussion. Yeah.
Next time.
Next.
I will try.
Okay, thank you,
very
thank
much
you.
For your.
Thank you very much.
I gotta go down for the business now. They asked me to talk about shootout business. Today, I gotta go to J&D office to talk.
바로 가셔야 돼, 지금?
Oh, yeah. This one.
아니, 여기 저 J&D 와 있고.
Yeah.